Hello, hello, Mr. Jose,
Hello,
Hello,
Dr. Yan. How are
Jan.
you?
How are you?
my older friend.
I have we have the feeling now that we are home.
Yeah, so long time not to
You are
meet you.
right. We met so many times in the past, in Israel, in your house, in China many times. I can tell you that my friend Dr. Dabby is very excited today.
Very
Yes,
true.
Well,
Shalom, Monica. How are you?
Monica.
Shalom, Miss Yossi. How are you?
Happy to
Long
speak
time
with
no
you.
see.
We are ready.
Since next week, last
Oh,
week. Mr. Debbie, how are you?
Fine, fine. Good to see you again.
Good to see you again. And we would like to express our apologize to you for the last time our careless mistake wasted you a lot of time and energy. So thank
No
you for your
problem.
kindly tolerance when we meet again.
Monica, I have to
And
tell you.
thank you for Mr. Yossi's effort.
When it's
I have to tell you something that it's a secret that even Dr. Debbie don't know about. I was very disappointed this day, but when we have a good friend like Dr. Debbie, he tell me, Yossi, don't take care. Mistake can happen from both sides. So we are so good friend and so different. So we have to learn about what happened and to overcome for the next. And this is what we are doing.
Yeah, thank you.
Are you ready?
Ready. It's Jennifer.
他讲了吗？
Yes,
Yes.
yes, we are
Okay,
ready.
so we
We are
can
ready.
begin with the small movie from our part. Please, Tomer.
אבינו מלכנו זכור רחמך וכבוש כעסך לך לדבר וחרב ורעב ושבי ומשחית ועוון ומגפה ופגרה וכל מחלה וכל תקלה וכל קטטה וכל מיני פורענויות וכל גזירה רעה ושנאת חינם מעלינו ומעל כל בני וריתך. אבינו מלכנו
延续啊。
זכור רחמך וכבוש כעסך ובך לדרך וחרב ורעב ושבי ומשחית ועוון ומגפה ופגרה וכל מחלה וכל תקלה וכל קטטה וכל מיני פורענויות וכל גזרה ושנאת חינם מעלינו ומעל כל בני ביתך. וכתוב לחיים טובים כל בני וריתך. וריתך.
truth behind the lies. Dark eyes lost in yourself. Come baby, gotta let me in. I'm trapped on a singular path, going nowhere and moving fast. So no, it's time to go. Yeah, I go alone. They say body doesn't fall very fast. Moon fall, no looking back. I know these boots find the road. I'm on the road. Blue sky, find the truth behind the lie. Dark eyes lost in silver. Come baby, gotta let me in. Blue sky, find the truth behind the lies. Dark eyes lost in silver. Come baby, gotta let me in.
Hello again. I have to say that today it's also for me something special. Do you hear me?
Yes, we can hear you.
I think that I have also the occasion to host Dr. Yan in our nice country.
Yeah.
Also in Ashkelon, also in Ra'anana. And I know that the connection, the professional and personal connection between Dr. Yan and Dr. Dabby, it's something that we want to teach how to build the right connection. It's not only an advantage, but it's friendship. And including in friendship, we can find for sure professional and friendship and right connection. And I know that during the 2 years of the COVID, many times I spoke with Dr. Dabby, and always his sentence was, we are expecting to the time that we will be able to see again our friend all over China, but especially some friend that he cooperate with them a lot. So first, this is our wish for the continuation, and I hope that this Zoom will be transferred very soon to personal contact. Dr. Yan,
Yes.
you are invited to give some words, please.
Thank you. Can you hear me?
Sure.
Yeah, we hear
Very
you
well.
well.
I've been to Israel for 3 times. Every time I got many things to learn. Dr. Dabby teach us many things. In our team, we often talk about over the wonderful time about we've been to Israel, and Dr. Dabby come to our hospital, to our orthopedics, to operation together, and Mr. Yussi, we sing 那叫什么歌来？Sing songs to me, to us. So every time it's very wonderful. We will continue to learn more things from Dr. Dabby and Matata. So today we have prepared some things to share with. I include over many teams. this lady is Dr. Ge. 介绍一下自己。
Hello,
没事，你就说就行。
hello, dear professors. I come from the Department of Anesthesiology, and I'm an anesthesiologist. 葛亚丽, thank you.
I'm a nurse. I'm 薛海霞. Thank you.
I'm an anesthesiologist. My name is Leon. Hello.
My name is Wang Jianjian. Thank you.
Can you hear me?
Yes, absolutely.
Yes.
Hey. Hello, Dabby. Yeah, I'm very glad to see you. Welcome to China and to together to perform the TKA.
Thank you.
Dr. Dabby,
Yes.
I don't know whether that you can know me that I am the person you have attending my wedding. So maybe you have the first time you attending a Chinese traditional wedding ceremony. So that I have my name is Li Xiaolei. I am a joint pain surgeon. So that I can show you that I have a baby, and she's and he is about 6 years old, and she will ready to attending a school, and he is graduated from the kindergarten. So maybe you have. Maybe next time you come to China, I can introduce you to. I can introduce him to meet you. Is that okay?
With pleasure.
It's a wonderful story. Meeting, wedding, born, and now is 6 years old. Wonderful.
Yeah.
I must say that looking at you all is really very exciting for me. And I wish that there will be a day, and better that it will be soon, that we will be sitting in the same room, not you in China and I'm here in Israel, but all of us together in the same room. Let's hope it will be soon enough.
Hello, Mr. Dabby. I'm the head nurse of the unit. Glad to see you.
Thank you. Glad to see you too.
Beautiful lady is our leader.
As always. Can you see us well?
הם לא רואים אותנו.
A very simple PPT for I prepared, but I want to learn your first.
אוקיי,
Okay.
אפשר להתחיל. Please, דוקטור דוד.
אז הם רואים? So this morning we are going to speak about advantages that were done with a total knee replacement. And actually, there are many new things. Some of the new things that I actually started with Professor Jan together, like the kinematic. But there are many, many things that are new, and I want to speak with you about it. And first of all, why do we need to change? Why not to continue the same way? And that's because in total knee replacement, unlike the total hip replacement, people were not so happy. And we wanted to have like 100% success. But unfortunately, as you can see, the satisfaction rate is about 89% when you ask the patients. And the only 91% says that they have good relief of pain. It's a lot, but still 10% are not happy. And see, only 66%, which is only 2/3 of the patient, feel that after the operation the knee is normal. But 1/3 of the patient doesn't feel so. So if we go to the red side, you can see that when you ask the patients and give them questionnaires, 1/3 of the people still have some pains. 40% feel stiffness. 1/3 of the people feel noises, swelling, tightness, etc. Almost 40% have difficulty getting in and out of a car. 1/3 of the people is having difficulties to get from and on the chair. And about half of the patients still have difficulty in climbing stairs. So, unlike the total hip, that you have what we call the forgotten hip, which means if you meet your patients after 10 years or so, and you ask him, how is the total hip we did to you? And he start to think, was it the left hip or the right hip? He doesn't remember because he feels so comfortable. The new hip is like his nature. But it doesn't exist so much with a total knee. And we wanted to have the same success in total knee than in total hips. So we want the 20% of patients that are not satisfied with their total knee replacement to be satisfied. Like the total hip, that only 5% of the patients are not satisfied. And that's why we feel that we have to change something. We cannot continue the same way. If we want to have better success, we must change. And that's why when we started to think how we can improve ourselves. And actually there are 3 ways. One is to change the prosthesis. Secondly is to change the surgical technique. And thirdly, to change the treatment and the rehabilitation. All the perioperative period should be changed. So those 3 things we are going to discuss, and we'll start one by one. First, everybody of you know Confucius, who was very, very clever. And he gave them 3 very important things. First of all is to look at the nature, to collect the fact, to see what's going on. Don't try to change the nature, try to learn from it. So first of all, gather the facts, then think about it, have reflection how to combine them and to create something. And after you collected the facts, after you thought about them, then you experiment and see what is the results of the thing that you did. If you follow those 3 steps of Confucius, you will see that it's the same nowadays, and you will have success. So let's observe the nature. If we really understand the knee kinematic, then we will be able to mimic it better, not to change it, but to look at it, to learn from it, and then to do our prosthesis with better kinematic. So we don't want to change the nature, we want to mimic it. If you can see, this is the medial side of the knee. And here you can see the medial collateral ligament. When the knee is straight, you see that it's very strong, very tight. And look here, when the knee is flexed, also the medial collateral is a tight, strong ligament. I'm trying to pull it, I cannot, it's very strong. And that's because the medial collateral is always tight when the knee is in extension and when the knee is in flexion. You can see it also in the MRI, when the knee is in extension and when the knee is flexion. The distance is almost the same. And also the contact point here between the femur and the tibia, also in extension, also in flexion, it's the same. It's the same area. If you look here, and if you look here, that's the lateral side. Here you can see that it's not the same situation. If you look here, when the knee is straight, the lateral collateral is tight. But when the knee is flexed, you can see that it's not so tight, and I can pull it. Also, the contact point between the femur and the tibia is now posteriorly. It's not like in here. So when we are talking about the medial side, the contact point is always the same. But in the lateral side, look, it's posterior. You can see it also well in the MRI. When the knee is extended in the lateral side, look at the distance and look at the contact point here. If the knee is flexed, you see that the distance is shorter and the knee is now touching on the posterior side of the tibia. So the kinematic of the medial and the lateral side is not the same, and we have to realize that. While the medial side is like a ball in a socket, and that gives a very good stability through all the range of motion. And there is no motion almost of the femur on the tibia. So we have to make the same thing in our prosthesis. So it will be all the time stable without no mid-flexion instability. The lateral side, unlike the medial side, gives more freedom, as you saw in the previous slides. So the femur can roll on the tibia from anterior to posterior. And this is something that we have to create in our prosthesis. So we had to change the prosthesis. So look here, the medial side is like a ball in a socket. So it has to turn You see it here in the exactly the same place with no anterior posterior movement, while the lateral side is built differently and the prosthesis can glide and slide from anterior to posterior. You can see it here as well. So the new prosthesis, which is called like the kinematic prosthesis or the medial pivot prosthesis, is built different than the previous prosthesis in order to mimic the nature, to give the better kinematic to nature. You can see here the contact points at different degrees, 20 degrees to extension to 100 degrees of flexion. It's almost the same in the medial side, but look how it varies on the lateral side. And still, we are not perfect. Look at the patellofemoral joint. It's also, we have to change it in order to avoid to get, when we get sometimes those things that the patella is subluxated. The patella should always be in its place.
So handsome.
Thank you. You see, I went to your office to take some coffee.
Yeah. Do you remember my coffee? In my
Here,
office.
Of course.
Yeah.
Hopefully it will be soon again
Yeah.
without this Zoom.
Can we continue, Dr. Dabby?
Yeah, we can. Again, have you seen this slide?
Yes. Yes.
Yeah.
Okay.
So what we were talking about, the medial side, the lateral side, and we said that still that we need to make maybe changes in the patellofemoral joint. It's not the same in all the people, and maybe in each person or in each prosthesis we should make some changes in this area. Maybe when we take certain femur, like femur size 2, 3, so it will be taking 2A or 3B, with each one will be with a different patellofemoral joint, and that will make us in the future even with better prosthesis. So we were talking up till now about the prosthesis, but you remember we said that we have 3 things. So the second thing we are going to speak is the surgical technique. Until now we were not doing as Confucius said, and we didn't observe the nature. We wanted to make every knee straight with the same appearance, but it's not like this in nature. Each one has his own varus or valgus knee. Look, in United States, you can see that the angle is between 16 degrees of valgus to 12 degrees of varus. In Belgium, for example, the range is between 5 to 8% valgus to varus. Why is that? Maybe in United States because there are many immigrants from different parts of the world, like from Africa, from East Asia, from Europe. So there is a variety of angles. While the Belgium, most of them were born and grew up in Belgium, so the variety is less. But still, only very, very small percent of the population have what is considered the perfect distal lateral femoral angle or the proximal medial tibial angle. Look here, it's not the same. even if we take the same angle between the femur and the tibia, you see that the patellofemoral joint is different. Look here, it's almost 90 degrees. Here it's more valgus, here it's less. Everything differs. So why to make everybody the same? It doesn't feel normal. Look at the population, how different it is from one to one to one. Every one of us has a bit of different valgus angle in the femur and has a different varus angle in the tibia. It's not the same. We were talking that in the tibia we want to create 90 degrees to the floor. In the femur we want to make 5 or 6 degrees of valgus. But why? It's different in every person. And if we don't make the same angle that he was born with, he won't feel natural. He won't feel comfortable. He will feel that he has some unnature, some prosthetic inside. And we don't want that. That's what we thought, that every knee must be straight and perfect, like those columns, and then it will last forever. But is this true? Not really. When we checked, and we did it once when we were in China with Professor Yan, we checked there is no problem in doing varus in the tibia. And if the patient had varus before and we are making varus after the operation, he will even like you. He will feel better. And if we say that because of the angles we will get loosening, not at all. Look, in the dot line is the perfect straight knee. In this line, you can see it's what we call the outlier group, the group that has a bit of varus, a bit of valgus. Look, after 20 years, their survival is even a bit better. So kinematic alignment, what we did with Professor Yan the last time we were in China, is actually better. The patient will feel better. Why? Because we looked, as Confucius said, we looked at the nature. We don't want to change it. We want to recreate the same thing that we learned from the nature. We want to recreate the varus vangulus turning axis. We want to create the same epicondylar axis. We want to recreate the posterior sliding angle of the prosthesis. And that's why we created what we call the kinematic prosthesis or the medial pivot prosthesis. You can see here the medial side. It cannot glide. It can just bend and straighten, while the lateral side is flexed, so the knee can slide on it and glide on it. And like this, we can recreate again the same things that we did before. So not restricted kinematic alignment is actually having something that we want to recreate. We want to get good stability on the medial side. We do agree to some degrees of laxity on the lateral side. And when we are doing varus valgus stress, we do agree that we will have 2 to 3 degrees of opening in the lateral side. So also we are talking about alignment. The kinematic alignment is actually focuses on balancing. That's the main thing of this method. And if we will balance well the knee and get natural alignment, and we will get also physiological balance, and that's our aim. And that was shown in all the studies that were published. Look here, from United States, from Korea, Canada, Great Britain, Australia. And with the help, if you remember, Professor Jan, Dr. Dragan, who was with us from Germany, we tried to even gather things from your experience in China and learn from it. And actually, those results that I have seen at the beginning that you did with Dr. Dragan from Germany were good results, and that made me very happy. Also, you remember that we were talking about the forgotten joint. So when you meet your patients after several years, all of a sudden he doesn't remember where his knee was. So we said that once it was just with the hips, but look, when we moved from mechanic to kinematic, so we start to get forgotten knee joint, and that makes great advantage and a huge step for us for patient satisfaction. We can compare the satisfaction and the longevity of kinematic versus mechanical alignment, and we see that the kinematical alignment is much better than the mechanical alignment. This is in the blue is the kinematic, while in the red it's the mechanic. I agree, it's not tremendous change. It's between 98% and about 93% satisfaction and longevity, but it's a difference. And why not to continue with that? And last but not least, he said that we will discuss 3 points. So that's the last one. It's the perioperative, how to treat the patient. We don't want just to be like carpenters, putting some prosthesis in, using some surgical technique. We also want to look at the patient, to speak with the patient, to be friend with the patient, to have him as friend of us. And that's the third thing that we are looking. And here is also for the nursing staff that is around the table here near you, Professor Jan. First of all, we want to be, before the operation, we want to meet the patient and to explain everything to him. Not just us, the doctors. He should meet the nurses, the physiotherapist, the occupational therapist, the social worker, everybody that he will meet after the operation. It's good that he will see before. Like this, when he comes to the operation, he will be less nervous. And if he is less nervous, he will be less painful. So before the operation, give him all the operation that you can. You can also give him brochures, because when you speak to him, he doesn't remember everything. But when he will get something written, He can, after that, look at it with his family, with his kids, his grandchildren, and then everybody together will discuss and explain to him. And that, as I said, will reduce the anxiety and will promote the recovery. So explain everything to him, show everything to him, the personal and even the department that he's going to be in. That's before the operation. While inside the operation also, he has to be explained. Everything should be clear to him. The anesthetist doesn't have to come, just give the injection, but speak with him, explain to him, and everything should be focused on rehabilitation. So if we are talking about aspects of anesthesiology, spinal and local blocks are much better than general. Pain protocols can be given, but try to avoid opioids so he won't sleep and he will be able to walk and to do the physiotherapy. We must take care of the wound and to avoid infection, to give him good food so he will feel better, he will feel strong, and the first priority, as we said, he can do quick rehabilitation. After the operation, if he can go home, do it, and as soon is better. Home rehabilitation is much better than rehabilitation inside the hospital. Physiotherapy can come to his home and to look after him. Everything at home, he will feel much better in his environment, in the bed that he is used to, with his husband or wife and the neighbors he is used to. He will be more active, and if he's more active, there is less chance of having DVT or everything. All complications are much less. Even if we look at the infection rate, much better at home, less than 100% in compared to 2 to 4% in rehabilitation centers. So try to send him home to his nature again. That will make him happy. And if patients are happy, the surgeon will be happy. Thank you so much.
Wonderful. Thank you very much.
Shishi.
It's I studied this PPT for several times, but not like you show us. The lecture is wonderful, I think. So I prepare a simple PPT for our team and
Great.
你分享，我得放下。Mr. Dragon's papers, she also showed me. Do you still do the kinematic total knee today, Dr. Dabby?
Today we are doing only the kinematic total knee.
Only,
At the beginning,
only.
yeah, we were doing at the beginning one mechanic, one kinematic, trying to see which one is better. And then one day the physiotherapist in the ward came to me and told me, you know, Dr. Dabby, I know exactly when you are doing total knee and mechanical and when you are doing total knee kinematic. And I said, well, you look at the operation notes. He said, no, those with kinematic rehab much better. After 2 days, they get 90 degrees of flexion, while in the mechanical alignment, I hardly succeed in 2 days to get to 60 or 70 degrees of flexion. At that point, I decided to abandon the mechanical and I'm doing only the kinematic.
Thank you. We also do about 200 kinematic, but
Wow.
the result of we think it's not so good like Mr. Dragon's result. I will show you the many problem in the our job, the first the ultimate goal of our job, our work is improve patients' satisfaction. Patients' satisfaction can help others to solve the problems and bring us more patients, and also bring us more income, leading the higher self-worth, update a better self, many things. But like you, like many articles show us, there are more than 20% patients is not satisfied. Even in 8% people said it is better to not do it. It's horrible. I think it's horrible. This is very interesting numbers, like the 80-20 rules. They also called Joyce law. Joyce law, yes, I find it. They
You are
think
great.
that 80% of the money in 20% people. So we should pay show our the 20% people is VIP. So we should use 20%, 80% things to the VIP. And another people tell us the one satisfied patients can bring us 7 new patients. But if one not satisfied people can let 21 people leave us,
Will run
so
away.
yes. So this 20% who not satisfied is more important to us.
Agree.
Yes. What happened? This 20% unsatisfied, there are many things. We think like so many bleeding, swollen, infect, knee function, and so many things. We try to prove it, but not very good. Like bleeding, we also try to use drugs, use some technique, but we found post-operative, the bleeding also very bad. Swelling is a very important things, very normal things in our department. We also try to many kinds of ways to help us in our team, but it's not very good. And the post-operative pain management is we also trying many ways, and before operation, the after operation, and post operation, and every time, but also not so good. We also use some other ways like eyes, we also use red and blue lights, but many people told me he want to die after post operations. So many things we must face it, and we want to ask you, in our team, maybe every members have a lot of questions. I suggest if you can show you the job in your hospital, not only operation technique. Yes, we will find we want the whole times.
I think
Yes.
with Yossi's help, we can do it.
Yes,
Yeah.
I believe that. So, how to improve the TKA patient's satisfaction? We still have a long way to go. There are still many difficulties to overcome, but we firmly believe that we will do it better because we have Matata, Mr. Yossi, and my friend Dr. Dabby. Thank you. Toda.
חמוד.
Thank you.
Jan, I
Do you
love
hear
you.
me? Can you hear me?
Yes.
First, I have to say
Yes,
that
clearly.
we are proud of the way of your feedback. The last week we had another LVC, and I said to Monica that I think that this way of double way, it's very good, and you improve it out. It means that you gave out the feeling that we can do more. I remember the time when I visit together with the German expert and Dr. Dabby, we visit your hospital when our target was to try to do more actively together. But for many reasons, the COVID and other reasons, we don't reach this point. I am sure that we will check what you ask for. I will speak with Dr. Dabby and with his hospital in order to be able to utilize this not so good time to improve the technique in the two parts. You know, when the people asked me in the past how we are looking for new expert, I always gave the same answer. We are looking for the right people, and after that for the right expert. Dr. Dabby is a proof that we are right. It means that the way that he wants to be involved to help you, to improve together the techniques, is showing that it's the right way. We have the problem of the COVID, but we will overcome, I am sure about. The way that you show now your problems in a very direct way. You don't say to give us something that is not right. This is the way to go on. And I believe that like we did it in the last 20 years, we'll find a way to go on for the future. Dr. Dabby?
Well, first of all, Jan, I love you, as I said. And what you showed is exactly what I say. So to see that we have in China and here in Israel, the same way of thinking is a wonderful feeling. It really made me very happy. And I miss you. I hope to see you in reality, not by Zoom.
Yes,
I
yes.
think that it was not up to the COVID period. We reached the right time to do effective exchange in the two ways. To ask Dr. Dabby and others to go more in your hospital in others, and to propose to you to come to practice more and more. We are feeling that you arrived to the same point that we are in Israel, but with a very, very big difference. That the practice in Israel, it's more and more and more giving good results. You need some push. And we'll do our best to help you.
Thank you. Thank you very much. We believe the things get better. This year, our operations getting changed. This year we do more total knee, not like Dr. Dabby come to our department. More is to the hip. So we want to learn more technique, new technique, deep technique from Dr. Dabby by Matata, by Mr. Yussi. Thank you.
Our pleasure.
还有什么问题没有？有问 Maybe there are so many questions to ask, like this is my sister and my sister.
Dear Professor, I'm very glad to join this meeting, and it's a good opportunity for me and to learn more about how to improve the patient satisfaction after joint surgery. As an anesthesiologist, we take great important part in multimodal analgesia, but we find some patients they suffer very serious pain and vomiting and nausea. Our Professor Yan said, I want to know about that. In your hospital, the anesthesiologist, how to practice multi-analgesia. As usual, we give patients L-strand guide and regional anesthesia and combined with spinal anesthesia. And after surgery, post-operative analgesia, we use PCIA, and the major medicine we use fentanyl and some medicine to cure vomiting. Thank you.
So first of all, you are most welcome to come next time with Professor Yan and then be with our anesthesiologist. We are doing mainly spinal anesthesia, and at the end of the operation we do LIA, local infiltration, using either steroids, anti-inflammatories with ropivacaine and adrenaline. And this cocktail we inject to the knee so it will last longer. But it's true that the operation is painful. So we have a protocol of after the operation that is very well built, and we start with anti-inflammatories, painkillers, and some as you said, anti-vomiting, and also against constipation. And also we gave some neuropathic pills, tablets, and that we give at times At the beginning, quite a lot, and then we lessen. After a few days, less. After 2 weeks, another step down, and we stopped after 6 weeks.
Thank you, Professor. And I also want to know the majority techniques of anesthesiology in your team. For us, we usually use spinal anesthesia and combined with regional anesthesia. But some big hospitals in our country, they will use general anesthesia first. So I want to know, in your hospital, the rate of general anesthesia is higher or spinal anesthesia is higher for the joint surgery? Thank you.
Spinal is always. I very rarely use general anesthesia. Very rarely. Maybe once or twice in a year, not more than that. It's mainly when the patient says, don't want to hear, I want general, then we do it. But except of that, nothing.
Thank you. We are the same.
Glad.
The time is so fast. I think our team prepares this way, prepare it today for several meetings, and we talk about several times. We think our numbers have many other questions. Maybe we will have more chance by Mr. Yussi. We will meet again. Especially we wish Mr. Dr. Dabby come to China.
You know, you have such a good contact with Dr. Dabby. It's much more than professional. I am sure that he will agree to cooperate again, mainly with you. It's a fact. But I think what Monica mentioned the last week, we are going now, I believe, in quite a new direction. It's not only the show, the lecture of our expert, but it's also, I think so, cases that you have to prepare for. I believe that till we will stay in the static situation that we are today, we are in Israel and you are in China. The best was to send Dr. Dabby to enjoy and work with you, but we cannot do it. But I believe in the way that you show your presentation, that for the future, after receiving the agreement of Dr. Dabby, I think that we have to begin to prepare cases really. It means that, and the cases will be sent to us before the presentation, like we are doing with you. It means that it will be a challenge for our expert to learn the material and to come ready to give you the right direction. This is my feeling, but for sure that it will be up to Dr. Dabby.
Okay, it's very good things. We will learn more things from you, like Hebrew, like singing songs, like yes, wonderful things.
Professor Ian, I think that the next time we will organize you and me together with Dr. Dabby a song together to show the level of our cooperation. Okay, you get it.
And with your wife, Professor Jan.
Okay, and with your wife.
Thank you. Yes.
Yeah, my wife is always
yes.
speaking about her.
Yes, I and my wife often talk about the Anna. Next times, Anna come to China to live in my home. Okay.
Okay.
So Dabby,
that's a deal.
I miss you. Yes.
It's
Say
mutual.
hello to Anna. Oh,
Anything more, Monica?
Thank you, Ms. Joseph and Ms. Dabby. Let's look forward for our next meeting,
No problem.
both online and on site.
I hope that we succeed
Yeah.
to solve the technical problem. I heard from Tomer that you found maybe what was the reason of the interruption in the middle, because except the technical, I think that we arrived to the right level. Thank you for your attention, and as usual, shalom from Israel.
Bye bye.
Shalom. Bye-bye. Thank you.